We tend to put a lot of trust in mirrors. You wake up, you look in the bathroom mirror, and you just assume that reflection is reality.
It's intuitive.
Maybe a tired reality, but an accurate one.
We treat it as a one-to-one copy of the world.
But today, we're diving into a stack of clinical notes that suggests when it comes to medicine, specifically looking down the human throat, the mirror is actually a massive liar.
It really is. We're looking at a procedure called indirect laryngoscopy, or IDL. It's one of the oldest, most fundamental exams in an ENT's toolkit.
And it sounds so simple.
It does. You take a tiny angled mirror, you put it in the back of a patient's throat, and you try to see the vocal cords.
And the source material we have today, it basically frames this whole exam as an optical illusion course. And we've got notes here on fallacies, hidden areas, and some really intense detective work.
Right.
Specifically on how to tell if a vocal cord is paralyzed or just physically stuck.
Stuck versus broken wires. And that is a massive, massive distinction in head and neck surgery.
So that's our mission. We are going to decode the illusions of the laryngeal mirror, map out the blind spots where disease loves to hide, and then figure out why a neck that crunches is actually a good thing.
Which I know sounds completely counterintuitive. A crunching neck sounds painful.
Totally. So let's start with the tool itself. The notes have this great section titled Fallacies in IDL. And fallacies.
Yeah.
Such a strong word for a medical text.
It is.
It implies we're being actively tricked by our own eyes.
We are. And it starts with just the geometry of the exam. You have to remember, you aren't looking straight at the larynx. You're looking at a reflection of a tube from an angle.
Okay.
So the first thing that hits you is the shape distortion. The notes call it the oval picture.
Because the larynx, the opening itself, it's roughly circular, right?
In reality, yes, but because of the angle of the mirror relative to your line of sight, that circle gets squashed into an oval.
Which brings us to the math. And this was the first moment in these notes where I had to just stop and really think about the implications. There's a specific calculation for how much the image is distorted. The notes say there's a foreshortening of the vertical axis by 1/3.
This is huge. I mean, think about what that means clinically. You see a lesion or a tumor on the vocal cord in the mirror. Your eye measures it. It looks like it's, I don't know, say 10 millimeters long.
But because of that 1/3 foreshortening, the reflection is lying to me. It's compressing the length.
Exactly. The vertical axis, the length running down the throat, is squashed. So that 10 millimeter spot you see might actually be 15 millimeters in reality.
Wow.
If you don't mentally correct for that, you are going to underestimate the size of the cancer.
And that's so dangerous because staging a tumor depends entirely on size and extent. You might stage a patient as a T1 tumor, an early stage, when they're actually much further along, just because the mirror shrank the image.
Precisely. That's a 33% margin of error built purely into the optics of the tool, and it gets worse with depth. The notes also highlight faulty depth perception.
Yeah, this reminded me of the warning on a car's side mirror. Objects in mirror are closer than they appear. But here, it's the opposite.
Right.
Or the depth is flattened.
It's flattened. The notes say the distance between the mirror and the vocal cords appears decreased. You lose the 3D structure. You can't tell how deep a tumor has invaded just by looking at that reflection because the z-axis is compressed.
So you have a squashed image that looks flatter than it really is. And on top of all that, we have the directional confusion.
The antero-posterior reversal. This is the hurdle that trips up almost every medical student.
I still struggle with left and right when I'm backing up a car, so I can only imagine doing this inside someone's throat.
It's tricky. In the mirror, front becomes back. The anterior part of the cords where they meet appears at the top of your mirror view, which feels like the back.
But left is still left.
Correct. Lateral remains lateral, so you have to flip the image vertically in your head, but not horizontally. It's mental gymnastics.
Right.
And the notes warn that this leads to specific localization errors.
Yeah, it says lesions appear slightly posterior than its actual position. So if I see a spot and think, okay, that's near the back of the cord, I'm probably wrong. It's likely further forward.
Which matters for surgery. If you go in expecting a tumor in the posterior third based on your mirror exam, and you get in there and find it's creeping into the middle third, your surgical margins change completely.
You might have to remove more voice box than you planned.
Exactly. All because of a mirror trick. And that's assuming you can even see the cord at all. We have to talk about the overhanging epiglottis.
Ah, the bane of the laryngeologist's existence.
Pretty much.
It's described as a leaf-shaped flap. And a lot of people, it just hangs right over the view, doesn't it?
It does. It's meant to protect the airway when you swallow, basically closing the hatch so food doesn't go into your lungs. But during an exam, it's like a curtain that won't go up. It blocks the view of the anterior commissure.
The front point where the cords meet.
Yes.
Which brings us perfectly to the next section of the notes. Hidden areas.
The blind spots.
I love a list like this because it's basically a map of here be dragons. These are the places where the mirror just fails us. We just mentioned the anterior commissure. Why is that specific spot so dangerous to miss?
Because the anterior commissure is where the cartilage framework is thinnest. If a cancer is hiding there, locked by that overhanging epiglottis, it can invade the thyroid cartilage very, very easily. By the time you see it, it might have already broken out of the voice box.
That's terrifying. Okay, next on the hidden list, the ventricles.
So imagine the vocal cords. Directly above them are the false cords. Between the true and false cords, there is this deep pocket. That's the ventricle.
Like a side pouch. Or like asking someone to look into a bucket that there's a secret compartment on the inner wall you can't see from above.
That is a perfect analogy. If you're looking from above with a mirror, you can't look sideways into that pouch. You can have a significant tumor growing inside that ventricle, and the vocal cords might look pristine.
So a patient comes in, they're hoarse, maybe they're in pain, but you look in the mirror and say, you're fine.
And that's the trap. You can't just trust the all clear from a mirror if the symptoms persist. You have to suspect the ventricle.
The list also mentions the subglottis. That's the area underneath the cords.
Right, and the cords aren't transparent. You can't see through the floor. So anything growing immediately below the lip of the vocal cord is invisible to IDL.
And finally, the postcricoid region and the laryngeal surface of the inferior epiglottis.
That last one is tricky. Remember that flap we talked about, the epiglottis? Yeah. The mirror sees the top of the flap. But if a cancer is growing on the underside, the side facing the larynx, you'll never see it with a mirror. You need a flexible scope to curl around and look back up at it.
So the takeaway here is that a normal mirror exam does not mean a normal larynx.
Precisely. It just means there's nothing obvious on the surfaces the light can actually reach.
Let's shift gears. We talked about structure. Now let's talk about movement. Because the notes make a huge deal out of the difference between restricted movement and fixity.
This is the most forensic part of the whole exam. The vocal cords are supposed to move. They open to breathe, close to speak. When one stops moving, you have a mystery to solve.
The notes list infiltration of the vocalist muscle as a cause for restricted movement.
That's usually early stage cancer. The tumor grows into the muscle fibers, making them stiff, so it can still move, but it's sluggish.
Okay.
It's like trying to run in heavy denim jeans versus running shorts. The muscle works, but the infiltration just drags it down.
Versus Mass Effect, which is just something big getting in the way.
Yeah, bulky tumor physically blocking the path. It's not infiltrating the muscle yet, it's just crowding the room.
But then we get to fixity. This is when the cord is frozen solid. And the differential diagnosis here, the list of causes, is really, really specific.
Fixity usually implies something has been destroyed or invaded deeply. The notes list infiltration of the recurrent laryngeal nerve,
It's the nerve supply.
specifically in the tracheoesophageal groove. If the cancer hits that nerve, the power line is cut. The cord goes dead.
But fixity can also be mechanical, right? The notes mention the cricoarytenoid joint.
The hinge. If you have, say, arthritis in that joint, or a tumor grows into the joint space, the cartilage is physically cemented in place. It can't move.
So here's the problem, and the notes have a whole table on this. You look in the mirror, one vocal cord isn't moving. How do you know if it's paralyzed from nerve damage or fixed from being mechanically cemented?
And this distinction determines everything about treatment. If it's the nerve, the cancer might be way down in the chest or neck. If it's the joint, the problem is right there in the larynx.
It's a real Sherlock Holmes moment.
It is. And the source table gives us 4 clues to tell them apart.
Okay, let's break them down. Clue number 1, position.
If the cord is paralyzed, the notes say it typically sits lower, it loses its tone and it kind of sags. But if it's fixed, mechanically stuck, it's usually in a normal vertical position.
So it's frozen, but it's frozen at the correct height because the support structures are still holding it up.
Exactly.
Clue number 2, the arytenoids. Those are the anchor points at the back.
In paralysis, you see arytenoid subluxation. They tend to flop forward because the muscle tension that usually holds them upright is just gone. In fixity, in normal position, they are upright, just locked.
Okay, clue number 3 is the one that really blew my mind. It seems so contradictory. Flickering movement.
This is probably the most valuable sign. The notes say a paralyzed cord will show flickering movement.
Wait, explain that. If it's paralyzed, if the wire is cut, why is it moving at all?
It's not purposeful movement, it's a quiver. It's called fasciculation. Even when a nerve is damaged, you often get these erratic electrical signals, or the surrounding healthy muscles transmit little shocks of movement into the dead cord. So the cord looks unstable, it just sort of twitches.
So paralyzed doesn't mean still, it means uncontrolled.
Exactly.
And a fixed cord.
Absent. Stone cold. If a tumor has cemented the joint or grown through the paraglottic space to lock the whole mechanism, nothing moves. No flicker, no wave. It is a statue.
That is such a nuanced observation. You're looking for a tiny twitch to tell you if the nerve is cut.
It requires a very, very steady eye. You have to stare at it and ask, is there life in that cord or is it cement?
And the 4th clue helps confirm it. Appearance.
A paralyzed cord looks wavy and thickened. It's flaccid. Think of a sail when the wind dies, it goes slack and wrinkled.
Right.
A fixed cord looks normal. The muscle itself might be perfectly healthy and taut. It just physically cannot swing because the hinge is broken.
So to summarize, if I see a cord that is sagging, looks wavy like a loose sail, and has a tiny flicker to it,
Paralysis. Start looking for a lesion attacking the nerve path somewhere.
and if I see a cord that looks totally healthy, sitting at the right height, but is absolutely completely motionless,
Fixity. The problem is mechanical. The tumor is likely invading the joint or the immediate framework.
it's incredible how much deduction you can pull from just watching it not move. But the notes don't stop at the visual exam. We have to put the mirror down and use our hands.
The tactile exam. You cannot diagnose laryngeal cancer without touching the neck.
The notes ask about tenderness. Is the voice box sort of the touch?
And the answer really should be no. Cartilage doesn't have much feeling deep inside. If you press on the larynx and the patient jumps, the notes say it indicates tumor invasion of inner perichondrium.
The perichondrium is like the skin of the cartilage.
It's the membrane wrapping it, and that's where the nerves are. So if the tumor has eaten through the cartilage and hit that wrapper, that causes pain. It's a sign of advanced invasive disease. It means the containment wall has been breached.
And then we have the sound. The notes call it laryngeal crepitus.
Or Broca's sign.
The definition here is so visceral. The grating sound produced by movement of cricoid lamina over vertebral bodies.
Essentially, you grab the voice box and you just wiggle it side to side against the spine.
You want it to grate.
Yes. We call it the laryngeal click or crunch. It sounds awful, like bone rubbing on bone. But that crunch means the larynx is free. It's rubbing directly against the spine, which is normal anatomy.
So the absence of the crunch is the bad news.
Exactly. If that sound disappears, it's a major red flag. The notes list the causes. Postcricoid tumors, retropharyngeal abscess.
Why does the sound stop?
Well, think about the geometry. If a tumor grows behind the larynx in that postcricoid space, it pushes the larynx forward, away from the spine.
It acts like a buffer.
A cushion. You wiggle the larynx, and instead of clicking against the vertebrae, it just slides silently on a pillow of cancer or pus.
So silence is dangerous. The crunch is healthy.
In adults, yes, but, and here's the curveball, the notes mention a physiological absence.
Right. In kids, neonates, and children,
The notes say it's absent because of unossified cartilages.
which makes total sense. Babies are soft.
Their cricoid cartilage hasn't hardened into bone yet. It's soft rubber rubbing against soft tissue. You can't get a grating sound if the materials aren't hard enough to grate.
I love that detail. It really highlights that context is everything. A silent neck in a 50-year-old is a medical emergency. A silent neck in a 5-year-old is just, well, it's just being a 5-year-old.
It reminds us that anatomy isn't static, it changes with time.
So we've covered a lot of ground here. The mirror that lies to us by shrinking tumors by a third, the hidden pockets like the ventricles where disease can hide, the subtle flicker that distinguishes a paralyzed cord from a fixed one.
And the importance of getting your hands on the neck to feel for that crunch.
It turns a standard exam into a real investigation. You can't just look, you have to interpret everything.
That's the art of it. You take the visual data, you correct for the optical illusions, you add the tactile data, and you build a model of what's really happening inside.
Before we wrap up, I want to leave everyone with a thought on that last point, the crepitus in children. We just said that the missing sign is normal for them because they are unossified. They aren't finished hardening yet. It makes you think about how we define pathology. Often disease is just the right biological process happening at the wrong time, or a structural feature appearing where it shouldn't. In a baby, a soft, silent larynx is perfection. In an adult, it's a warning. It's a good reminder that in medicine, you aren't just examining a body in space, you're examining a body in time. That's a really profound way to put it. Check your blind spots, everyone. Thanks for diving in with us.